For those of you who haven't had a chance of meeting, my name is Clark Veet. I'm one of the chief medical residents. I'm really honored today on behalf of Dr. Rubin to introduce our speaker for Medicine Grand Rounds. Today, we have the privilege of welcoming Dr. Amish Adalja. Dr. Adalja is a preeminent voice and thought leader within many important clinical spaces. Clinically, he's a quadruple threat with board certification in internal medicine, emergency medicine, infectious diseases, and critical care medicine. His research interests reflect his broad training with numerous publications and leadership positions relating to vaccine safety, radiation toxicity, bioterrorism, and emergency preparedness. In addition to his clinical and academic roles, Dr. Adalja currently serves as a senior scholar at the Johns Hopkins University Center for Health Security. Please join me in welcoming Dr. Adalja for a timely report on the mechanics and dynamics of the influenza virus.
Thanks everybody for coming to see me speak, and thanks for that introduction. So, like you just heard, I kind of have multiple different roles, and I would say that influenza is something that crosses all of the roles that I have, because it is something that is probably the biggest global catastrophic biological risk that human beings face. And what I'm going to do is try and take you through why that is the case. And feel free to interrupt me and ask me questions, and I hopefully will prompt a lot of thinking and maybe say some things that are a little bit controversial, and I'm happy to go back and forth. So what I'm going to get you to do during this talk is really understand the history of influenza, because that's what really conditions how this disease has spread across the globe and why it is on the top of everybody's threat list. I want to try and break down this year's seasonal influenza epidemic, because this was something that people were really having a hard time wrapping their mind around, because it was it was in some ways worse than a pandemic season, in certain ways it was less than a pandemic season, and in certain ways it was expected. But what really happened this season and what explains it? Talk a little bit about the diagnosis and treatment of influenza, some of the new avenues of research with vaccines and how vaccines fit into the whole control of influenza. And then lastly, I want to talk about some of the highly pathogenic forms of influenza, which I think are the most scariest viruses that there are in the world today. So influenza has been around basically as long as humans have been in settlements, because when humans were interacting with each other, it became very easy for a respiratory spread virus to move between humans. So the first description actually goes all the way to Hippocrates in 412 BC, where he describes something called the cough of Perinthus. And if you read Hippocrates' works on this, it's actually very, very clinically identical to the descriptions of flu that we have today, with the cough, the myalgias, the fever, all of that. So you can clearly recognize influenza was present even in ancient Greece at the dawn of modern medicine. But people didn't know what it was. This is now centuries before the germ theory of disease, or before even a virus was discovered. And what people realized about flu was that it had this chronic periodicity. It occurred at certain times, and we recognize that as our flu season, in the fall, in the winter. And what people thought was that this had to do something with an astrological phenomenon, that it was the influence of the stars. And that's where the word influenza comes from. It's an Italian word for the word influence, and that's what people believed. And I think it was interesting that this periodicity in outbreaks was recognized right away. And they knew that this was seasonal. It happened every year, and sometimes it would be very bad, and those were pandemic years. And we've had major pandemics in the 20th and 21st century, and just a couple of points on each of them. So in 1918, this is probably the biggest infectious disease emergency humans have ever faced, where you had 50 to 100 million deaths around the world at the end of World War I, and it basically changed the face of the globe, because this was the first infectious disease outbreak in the modern era that really impacted societies in a way that you can't really describe today. It would be hard to even fathom, with people running out of coffins. And even in Butler County, where I grew up, there are mass graves with markers there from the influenza outbreak. So this is something that you can't really underestimate. Then it flu quieted down for a while, and then in 1957, another outbreak occurred, which caused about 70,000 U.S. deaths. This was a shift, and I'm going to talk about that in the virus, to the H2N2 from the H1N1 that was present in 1918. And then in 1968, we had another outbreak. Some of you might be old, some of the older physicians in the crowd might remember it, which caused 33,000 U.S. deaths. 1977, we kind of had a mini pandemic, which I'll talk about later on. It really wasn't a pandemic, but it's the reason why we have two circulating A strains now, H3N2 and H1N1, because of what happened in 1977. Because before that, it had really been only one A strain dominating. And in 2009, which most of you will remember, we had our most recent pandemic, the swine flu pandemic, which gave us our current H1N1, and that caused about 13,000 deaths. And I'm going to try and deconstruct that a little bit because I think there are some misnomers about that pandemic that it wasn't really that bad. This is a picture in the 1970s during the swine flu scare that happened during the Ford administration. It's a picture of Gerald Ford getting a vaccine, showing you how pro-vaccine a president could be and how useful that could be during a public health campaign to see leaders being vaccinated. But this swine flu epidemic in 1976 really conditions a lot of people's views on pandemics and also on the vaccine. So what happened, just to give you a couple points. So at this point, people were really looking for the next pandemic virus. 1968 pandemic had occurred and people were very nervous. And they knew at that time that the way 1918, the trajectory began. So what happened was in Fort Dix in New Jersey in 1976 at a military base, 13 soldiers had severe respiratory illness and 1 soldier died. And at that time, they're surveying respiratory illnesses, looking for novel viruses. And what they find is a novel H1N1 virus that has most of its genes originating from pigs. So this is a novel virus that the human immune system is very naive to, and it's killed people, and it's in an outbreak setting. And 230 soldiers get sick. What ends up happening is the United States launches a major vaccine campaign, and you saw a picture of Gerald Ford getting a vaccine to get that vaccine into people's arms as quick as possible because they believe a new pandemic threat is imminent. However, it was a false scare. This virus wasn't very transmissible from human to human, and it basically stayed limited to Fort Dix. And what ended up happening is Guillain-Barré syndrome, which can happen with any infection and can happen with any vaccine. There was clusters of Guillain-Barré syndrome that occurred that really got people against this vaccination campaign and probably biased people against flu vaccine for a long time. And some of those Guillain-Barré cases were happening in the Pittsburgh area when this happened. And that really conditioned the way people thought about swine flu and rapid vaccination campaigns. And most of that was all false, but I think this was an important thing that conditions many people's minds on influenza, and the CDC director lost his job over this at that time. So what is it about influenza viruses that makes them so scary? Why do we always think about influenza? Why is it at the top of my list? So these are kind of the basic facts to know, and you may have remembered them from microbiology class, but we're going to put them in a new light. So this is an RNA virus. RNA is less stable than DNA, therefore it will mutate more. So I'm going to kind of give you the highlights of why flus are so scary. It's a negative strand virus. Most of the bad stuff tends to be negative strand viruses in general. The thing about flu is its genes are on segments, 8 different segments, like 8 playing cards in a deck of cards. And those segments can reshuffle, and I'm going to talk a little bit about that, but that's one of the major advantages flu has over many other viruses in causing pandemics. There are 4 types. Most of you have heard of A and B. There's also a C, and now there's a D. It's A that causes pandemics, and I'll talk a little bit about why that is. It was first isolated, the virus, in 1933. So from the time of Hippocrates till 1933, there was no virus, and people thought it was other things. They thought influenza was caused by Haemophilus influenza, which you've heard about, or Pfeiffer's bacillus, because it was isolated from so many people with flu-like symptoms that people believed it to be the cause of flu, but it was actually just a hanger-on. Waterfowl are considered the natural host for type A, so things like ducks, for example, and all the types of flu, all the H's and N's, there's 18 H's and 11 N's, all of them naturally are in waterfowl. B does not go in, B and C and D are not necessarily in that same kind of circulation. And that's why A's have this ability to reassort and recombine with all different new cases, new H's and N's, and come out with a novel virus. That's why A's are the ones that cause pandemic. Swine are interesting because they can be mixing vessels, because they can be infected with multiple different strains at once, some that are human, some that are all bird, and then they can reshuffle the deck as well. So swine play an important part in the ecology of viral pandemics with flu. We talked about hemagglutinin and neuraminidase. Everybody knows it. So right now, we have an H1N1 circulating and an H3N2. This season was dominated by H3N2, but there are other ones. The 1957 pandemic was H2N2. So that's the way we talk about flu, is those 2 genes. And flu is spread via droplets. So that's sneezes, coughs, things that fall about 3 feet from your body when gravity takes the droplet particle down. There is some airborne transmission. It's probably less important than droplet, but it does occur. And we often will recommend people use airborne precautions during aerosol-generating procedures, like, for example, a bronchoscopy. So when you look at flu, and we talked about these segments, this is just an example of what happens when you have a pandemic. So on this slide, you can see 1918, these are the 8 segments that you see there on the left of the screen. And what ends up happening is those segments all are from birds, and that's why you get a novel virus. But then what happened in 1957 was the H1N1 virus, which now has become human adapted, recombines and reassorts with an H2N2 avian virus, and you get something novel. So that's the problem that ends up happening with flu. It's like you've got people with different playing card decks, and they're getting mixed up every time, and that's why a new pandemic virus comes out. It's people using just reshuffling of those decks of genes, giving you novel combinations, and that's why flu will always do this, because you can think there's how many combinations of H's and how many combinations of N, plus all those other genes that can be recombined. So this is why flu will always be a huge threat, and why it's so desperate that we need a universal vaccine, because remember, our vaccine targets the H primarily. And that's the thing that switches. And that's what happened in 2009. We basically had a triple reassortant H1N1 that was in swine that then combined with another swine virus from Eurasia. So you had basically a quadruple reassortant virus that caused the 2009 H1N1 pandemic. And this is typical for what would happen with flu, but this is kind of the granularity that you have to use to try and figure out what exactly is this new flu virus. It can take pieces from lots of different places. So flu, the epidemiology, we talked about the winter seasonality that people noticed all the way back in ancient Greece. Attack rates can be as high as 10 to 40%. That means in a population, 10% of that whole population, or the city of Pittsburgh, for example, or whatever you're talking about, can be infected with flu. There's something called antigenic shift, which we've talked about. That's the reshuffling, where the H's and N's completely reshuffle and you get a novel thing coming out. That's what happens for pandemics. So 2009 was an antigenic shift. H2N2 in 1957 was an antigenic shift. But what happens year to year, and why we need to update the vaccine every year, is what's called antigenic drift. These are these little mutations that accrue and over time change the virus such that our immune system doesn't necessarily recognize it that well. And that's why we always have to update our flu vaccine, because it's targeting the hemagglutinin, which can get mutated, and that's what that drift means. Usually during a season, you see what's called as a U-shaped pandemic curve. That means that the deaths and severe disease are at the very young and the very old. But what happens in pandemics is that you get this W shape, and I've got a slide about that in a second. And the W shape has to do with the fact that you get clusters of deaths in people who are in the prime of life, because they haven't been, they're the ones that often that bear the bulk of the burden of pandemics, and I'll talk about why that is. Each year, flu kills about 3,000 to 49,000 people every year, so this isn't a benign illness. Much more than when people were worried about Ebola, this wasn't something that was going to reach this kind of a scale. Ebola was never going to reach the scale of flu. And this is what I'm talking about by the U-shaped pandemic curve. You can see that very young, very old, that's where you see pneumonia and influenza mortality, acute respiratory distress hospitalizations, and visits. That's where this cluster is. But when in a pandemic, and I have a slide about that showing where the peak is actually in the middle as well. I want to emphasize in this room pregnancy as a risk factor. I think it's very underappreciated, and it's something that needs to be drilled into everybody's heads over and over again. That pregnant women are 1% of the U.S. population, but during the 2009 pandemic, they accounted for up to 6.3% of influenza-associated hospitalizations, 5.9% of ICU admissions, and 5.7% of deaths. So this is a huge burden when you think about what pregnancy does. And these are the women who are afraid to get a vaccine, and these are the people who OBGYNs don't want to vaccinate. These are I've seen pregnant women trying to get a vaccine at a drugstore, and the guy saying, the pharmacist saying, I don't want to vaccinate you. You can get that at your doctor's office. Because people are worried about this. But the best thing you can do for a pregnant woman and for the developing fetus is to vaccinate that person, because this is huge. And this also plays a role in antiviral medications as well, because these are high-tier groups for giving antiviral medications, irrespective of that 48-hour window that people kind of use as a stiff rule. Influenza usually peaks in February, and it peaked this year in February, so we kept saying the peak is coming, and it usually traditionally is in February, and then it winds down. This is what I'm talking about with the W-shaped epidemic curve. So you can see in the seasonal, in the dotted line, you see the U-shape, but then in 1918, you see this big spike in the 20-year-old range. And that's really important, because if you think about the burden of influenza, and you think it from a public health standpoint or economic standpoint, if people that are 75 years old are dying of influenza, that's not going to have the same kind of impact on the workforce, on the world, as if people are 35 that are dying from influenza. So when you look at the 2009 pandemic, the average age of death was 37.4. That's it. And then you see how many years of life were lost. And if you look at that, this is a pretty severe pandemic, because the people who were dying were 37.4 years old. So that was, and look at 1918, 27.2. So this is really important, that even though you don't see people dying in the street, if you're seeing a lot of people that are 37 years old dying of flu, that's really going to have a burden. I think it's important that you, when you think about pandemics and you say, oh, that swine flu scare that happened in 2009, it wasn't a scare. It really was an impactful pandemic. It just wasn't really contextualized properly. The average age, 75.7 is what an average age of a death is from flu. That's really different than 37.4. So I hope that point is clear, that pandemics do have a huge impact on the population because of the people that are dying. And why is it that pandemics, you see this kind of earlier death, 37.4, 27.2? This is a paper I wrote with one of my mentors, D.A. Henderson, who was the man who eradicated smallpox and died about a year and a half ago. And what he remembered from his early times was this concept of antigenic sin. So the flus that you grow up with, the ones that you're infected with as a child, you're always going to have some immunity to them. So that's why during 2009, because a lot of the elderly who were born between 1918 and 1957, when the 1918 virus was prevalent, didn't have much burden of illness from 2009 because their immune system was primed to it. So for me, I was born in 1975. I was probably primed to more of the 1968 H3N2, but somebody that's born in a different age cohort may have different experiences with flus. So where you were born and what flus were circulating was going to carry with you, and that's this concept of antigenic sin that we wrote a paper about that was published in Emerging Infectious Disease, but now it's really come to the fore because of what's been shown with multiple different, even in seasons, who's getting sick and who isn't getting sick. So how do you gauge a season? So we talked about what a pandemic does with deaths, and that's kind of one crude thing, looking at the pneumonia, influenza mortality. What the CDC does is looks at different measures. So ILI visits, influenza-like illness visits. So these are sentinel doctors' offices that are tracking who comes to see them with a URI, and they keep track of that. Hospitalizations for flu or pneumonia or upper respiratory infections. Pneumonia, influenza mortality, which is the one that's very commonly shown. Pediatric deaths, the number of positive flu tests. So there's lots of different ways you can gauge a season. And the CDC just published a paper that came out in the American Journal of Epidemiology looking at this, and it doesn't project well, but I just want to show you that not every, so when you look at how many seasons were high, there wasn't that many. 2014-15, which most of you should remember, 2003, 2004, which is probably the worst one we've had in several years. But all these other ones were low to moderate, and they're looking at all of the different types of markers. ILI net, how many people are coming in for outpatient illness, hospitalization, mortality, looking at those types of stuff, and that's really how you can gauge it. And sometimes this is different because it can be different for the elderly and for the children. You can have a very high season for the elderly and a very low season for the very young, or vice versa. But if you look at 2009, 2010, that's where you see uniformly basically the highest numbers. ILI net numbers was 7.7, FluServ net was 10.8. They're pretty high, but it only overall ranked as a moderate season. But in terms of outpatient illness, it was very high. And those of you who can remember, doctors' offices and emergency departments were basically crowded with flu. So I call this slide a season to remember because I think this is the worst season that most people do remember, and I think people do forget seasons really quickly. But this is some of the data that emerged from this season. So if you look at the season here in red, you can see it almost hit the pandemic is the one on the very far left. It almost hit the pandemic level in terms of ILI visits, outpatient visits. And you can look at the pneumonia and influenza mortality curve. So these are the people that were dying of pneumonia or influenza. They just look at death certificates because they assume during flu season that most pneumonia deaths have some component of influenza. And you can see how high it peaked towards the edge there, that it was pretty high and crossed the epidemic threshold. So it was a pretty severe season. We knew this wasn't a surprise though. Remember, the southern hemisphere has the opposite flu season than the northern hemisphere. So right now they're about to start. They're getting ready for their season to start as we go into summer. Their summer prior had a very strong dominance of H3N2, and they had issues with vaccine efficacy there, with rates as low as maybe 10%. So we knew that this was going to be bad, and I'll talk about why there was not much you could do about it with our current vaccine, but this was something that we were expecting to see because of the Australian and Southern Hemisphere experience. So I think it's important that you remember that the Southern Hemisphere and the Northern Hemisphere, they kind of learn from each other's seasons to see what's going to come in the next season, what strains are circulating, and what to expect. So what is it about H3N2? H3N2 is somewhat a more virulent virus than H1N1. It tends to cause more deaths, more hospitalizations, definitely in the elderly, in the extremes of age. So when you see a season dominated by H3N2, it's usually going to be hard on the elderly. And maybe that has something to do with antigenic sin, because maybe they were born before 1968 and they grew up with the H2N2 virus and they're primed to that one, and they didn't have as much experience with 1968. But traditionally, when you have an H3N2 season, it's going to be worse on the elderly. So I call this eggs are for omelets, and I think this is an important point to know. Flu vaccines have been made essentially the same way since the 1940s, using eggs. So what that means is they grow the virus in eggs. And what ends up happening is, when you put a virus in an egg, you get this H3N2 that you want to make a vaccine against. You put it in an egg and you propagate it. That virus is going to then adapt to the egg. It's going to develop mutations that make it replicate more efficiently in eggs. So you cannot expect that what you started with is going to be what you end up with, and whatever you wanted to do is not necessarily going to be what actually you do achieve, because these mutations are going to accrue. So T160K was a major mutation in the H3N2 virus, which is an egg adaptation mutation that decreased the efficacy because it's not the same virus anymore. And there's lots of different papers talking about how changes like glycosylation cycle, why this happened. The other thing about eggs is it takes a long time to grow things in eggs. It's not some easy process, and things don't grow so well in eggs, and it takes a long lead time. So just in February, we picked our vaccine for what we're going to be giving people now in September and October. What happens if something changes now in between there and there? Nothing. You can't do anything. You're stuck with that vaccine because the lead time is so long because we're using eggs. So I think eggs are something of the past. They were something that worked for a while, but there clearly are major issues with egg-adapted vaccines, and I'm going to talk a little bit about different alternatives towards the end of the talk. So how do you get infected with flu? What flu does is it binds to receptors called alpha-2,6 sialic acid receptors. So they're neuraminidase is the fancy word for it's the other word for sialic acid. So they are in the upper respiratory tract of humans. So that's all our flu viruses, the H3N2 that's probably upstairs on the floor. That's binding to alpha-2,6 in the upper respiratory tract. There is another type of receptor called the alpha-2,3. That's more in our lower respiratory tract, but it is the preferred receptor of bird flu viruses. So if a bird has these receptors all through their GI tract, and the flu virus is binding to that receptor. But so now, when you ask, why do people who get bird flu in China, for example, have such severe pneumonia? It's because the receptor for that virus is deeper in the lungs. Does that make sense? So alpha-2,3 receptors in humans are much more distal in the distal airways. That's why you get more of a pneumonia picture. One of the reasons why you get more of a pneumonia picture than an upper respiratory tract picture. And what we look for in flu viruses in birds is adaptation. Are they getting the ability to bind alpha-2,6? And that's a scary thought, because that's when, if it can bind to alpha-2,6, it could probably do efficient human-to-human transmission. So we really look to see this change in receptor tropism, and there's a lot of surveillance that goes on in China looking at the receptors, each isolate. The other thing is, pigs have both receptors that can bind everything. That's another reason why pigs can serve as mixing vessels, because they have both receptors throughout their body. So the picture is Edvard Munch, the artist. That's a picture, a self-portrait during the 1918 influenza pandemic, which he was part of. So flu is acute, usually self-limited febrile illness, abrupt onset, 1 to 2 incubation period. What makes flu so hard to control in an outbreak setting is that it is contagious 1 day prior to symptom onset. So you could be incubating flu and not know it and spreading it. So during 2009, there was lots of calls to close the border with Mexico, but it made no sense, first of all, because we already had cases in the US, so there was lots of reasons not to. And the fact is that's not going to be helpful with flu, because how can you tell if somebody is incubating influenza if they are not sick? And remember, many cases are mild. About 25% of people who are contagious for flu have no symptoms at all. So this is a virus that's very adept at spreading, and I think contagiousness prior to incubation period is one of the most important factors that an infectious disease can have to facilitate its spread. Fever, chills, malaise, myalgia, eye pain, cough. Myalgia is something that I always stick out for, even if your rapid flu, I'll talk about rapid flu tests in a second, but you can't really rely on them. But one thing you can rely on, I think, is myalgias in the middle of flu season, because I do think it's very characteristic. 3-day duration, convalescent period, and you can have an asymptomatic rate that can reach even up to 50%. So this is a very good virus when you're talking about spreading through the human population. Complications, primary viral pneumonia is something that usually occurs in young adults, and it's this relentless progression. They get the flu, and then it just gets worse all the way through. And this is what you often see with bird flu viruses like H5N1, setting off a cytokine storm where you have this exuberant immune response, and it has a very high mortality. The other one is secondary bacterial pneumonia. This is what happens in elderly patients where they get better and then they worsen. And this is characteristically where Staph aureus is present. So when you have these types of cases, you have to cover Staph aureus and you have to cover MRSA until you get more information back. H. influenza, this is where it gets its name because it was so often a co-pathogen with flu. Strep pneumo, strep pyogenes. And when you looked at sections from 1918 of soldiers who had died of the 1918 pandemic flu, most of them died of secondary bacterial infections, probably driven by the lung destruction that occurred with the primary viral insult. And I think that this is important because there's some important treatment issues I'm going to talk about with macrolides here that are kind of fascinating stuff with flu. A couple other complications that are rare: myositis, myocarditis, Guillain-Barré syndrome. Guillain-Barré syndrome is more common with flu than it is with the vaccine. It's important to tell people that. Rye syndrome, which is an aspirin-related hepatic encephalopathy that happens with hyperammonemia. That's why you don't give aspirin to children. More likely to happen with influenza B for those of you who have to take board exam questions. And ARDS. During 2009, my colleagues and I at Presby saw, this is a paper we published where we saw aspergillus cases, which was really, really fascinating. This had been described before, but we had 3 cases, 2 at Presby, 1 at Passavant, and we collected all that data, and that's a picture of our bronchoscopy that showing you the aspergillus adherent to the airway. This is something that had been described before, but I think it was very interesting to see how immunosuppressed those patients became and how sick they got, that they were able to be colonized and then infected with aspergillus. Influenza B, most of you probably don't think it's a bad disease. I just want to tell you it is a bad disease. It doesn't cause pandemics, but for the individual patient, it can be just as deadly as influenza A. And when you look at this chart here, looking at what happens with hospitalizations and ICU admissions, they are about the same for influenza B and influenza A. So don't discard it if people have influenza B. It's not going to end the world, but it's probably going to be, it could be a tough, rocky road for your patient. So how do you diagnose influenza? Clinical suspicion during the season is usually sufficient to say that person's got influenza. Remember the Southern Hemisphere, so in the middle of summer, if you've got somebody that's got flu-like symptoms and they were just in New Zealand, maybe they have the flu. So you remember that as well. Rapid antigen tests. They have just been up-classified by the FDA because they are very dangerous to rely upon. People die because people rely on the rapid antigen test. They are very specific, so if it's positive, it will help you. But if it is negative, you cannot rule out influenza. It's like flipping a coin. These rapid tests, most hospitals don't use them. UPMC has basically gotten rid of those for good reason, because they are not reliable. But lots of these urgent care centers do use rapid tests and tell people they don't have the flu and send them out. And maybe they needed Tamiflu, maybe there's an infection risk because they live with someone who had a bone marrow transplant. That's really important to remember. Molecular diagnostic tests like PCR are the tests of choice. They are now CLIA-waived forms. So 3 companies, Alere, BioFire, and Roche, all have CLIA-waived flu tests, molecular diagnostic tests that can be employed in doctor's offices and emergency departments. The uptake is very low because it's very hard because everything is siloed. Pathology departments like to have these things, and they don't necessarily let things go into emergency departments. But I do think you're going to see more use of these because they are very reliable. The negative is reliable, and you can give people a proper diagnosis. And some of them, like the BioFire test, gives you a whole panel that you can say you've got paraflu, you've got coronavirus, you've got adenovirus, and people. I think this has a really good stewardship role because if you can tell people that you've got a specific virus, they're less likely to ask for antibiotics. And I think because people like to know exactly that they've got paraflu too, they put it on Facebook, they put it wherever they want to put it, and then people can sympathize with them over that. If you just tell them you've got some viral illness, I don't know which one it is, it's probably one of a dozen, that's not satisfying, so they still want their Z-Pack. So this can get rid of the Z-Pack push. Viral culture, immune fluorescence as well, you could do to diagnose it, but really it's molecular diagnostic tests is where we should be focused here. So a little bit about some of the treatments. I'm going to talk about the antivirals, the adjunctive antibacterials, other adjunctive stuff, and some rescue strategies. So there are a couple classes of antivirals to know about. The adamantanes, most of you have heard of amantadine and rimantadine. Amantadine is now used more probably for Parkinson's disease and traumatic brain injury because of all its CNS side effects actually are helpful for those conditions. And right now we have widespread resistance in our seasonal flu to the adamantane class, so they're not really used anymore. The workhorses are really the neuraminidase inhibitors, and there's 3 of them. Most of you probably have heard of 2 of them, oseltamivir or Tamiflu. zanamivir or Relenza, which is inhaled, and then peramivir, which is an intravenous formulation, which is 1 dose. So these are the 3 that are available right now. Oseltamivir is the only oral one, and that's why it's used so much. Ribavirin, which you know from RSV and hepatitis C work, that works as well with influenza, but it's not FDA approved for that, and it is toxic, and it is very teratogenic, so it's not really been used. And nitazoxanide, that's brand name is Alinea. That's a drug, an anti-parasitic drug that likely has influenza activity as well. Sometimes people use it down the line for C. diff when people have a severe vancomycin allergy, or they use it as an alternative in those cases, but that's an anti-parasitic drug that has antiviral activity. So this is what we use, but oseltamivir is really the one that you use the most here. So the adamantines, I mentioned earlier, they're M2 inhibitors, so they work differently than the neuraminidase inhibitors, but they only work on influenza A, which is one of their drawbacks. And these side effects, this insomnia, dizziness, difficulty concentrating, has made people really not want to use them, and we've got widespread resistance. Now here's what I want to, this is where I may get a little bit controversial with what some people talk about with neuraminidase inhibitors. So we talked about oseltamivir, zanamivir, peramivir. There's this thing that people stick to, this 48-hour rule, and I think it's better to give the flu, anytime you give an anti-infective agent, it's better to give it earlier than later. But 48 hours is not some magic cutoff, and it doesn't apply to everybody, because that 48 hours is really derived from outpatient studies of healthy people who had the flu. Not pregnant women, not immunosuppressed people, not people who needed to be hospitalized, and it was really designed to show decrease, the study was powered to show decrease in symptoms. It wasn't powered for all of that other stuff. So when you see the fact that people say, well, there's no randomized controlled data that shows that it decreases mortality or ICU stays, that wasn't what those studies were done to do, and it's now unethical to do them because we know that this is an effective antiviral drug. But we've got lots of retrospective data showing decreases in mortality, length of stay, shedding. And I know that the randomized controlled trial is the gold standard, but that doesn't mean all this data is invalid. And I do think that this is dangerous when people do not give it because of that 48-hour thing, using it as some special cutoff, that it's like filing your taxes, it's later, it's not, that's not the case. And delays in treatment during the pandemic, the median delay was 3 days. And among those requiring ICU admission, the delay was 7 days. Among deaths, 8 days. So clearly people were not using Tamiflu the way it should have been used. And so then in 2013, Michael Eisen at Northwestern wrote this paper talking about, so the 2013 season, 15% of PCR-confirmed flu cases got antivirals. So what happened to the other 85%? 30% of them got antibiotics with a positive flu PCR. So this is really horrible. And this is an editorial from CID saying, failing our patients by suboptimally treating influenza infections. So there is this really misconception that flu is just okay, it's just benign. And I think this really shows, even 4 years after the pandemic, people were still doing this bad. There was this controversial Cochrane review by Jefferson et al., where they really went after Roche and went after Tamiflu. What the premise was to only include randomized controlled trials with neuraminidase inhibitors. And when he did it, they didn't find any preventing complications. They showed mild effect on symptom durations. But remember, this was randomized controlled trials, and they didn't have the retrospective data. They didn't include it. And I think that really limits the generalizability of this, because even though there's no randomized controlled data, it doesn't mean that the retrospective data is invalid. A couple of things with antibacterials. You want to cover the usual suspects. I mentioned them earlier: Staph aureus, MRSA, H. flu, group A strep. So one of the things that happens is that you get, when you lyse a bacterial cell, there is an inflammatory reaction. And beta-lactams, remember, are cell wall active agents. So there is a lot of emerging data that using drugs that are protein synthesis inhibitors, like azithromycin or clindamycin or linezolid or tadalafil, one of those types of drugs might have an ability to dampen this inflammation. So there is some evidence in mice models using beta-lactams with azithromycin, for example, with strep pneumo, having less lung damage. So some people will still use a second agent there. There is a lot of effort trying to find immunomodulatory therapies like steroids, but that doesn't necessarily, steroids maybe for ARDS, but not necessarily for flu. PPARs, for the people who like endocrinology, rosiglitazone, pioglitazone, have an immune modulatory effect. Gemfibrozil, which is a fibrate, statins, COX-2 inhibitors, all of these things probably have some downstream effect on flu. And there was a paper that recently came out in CHEST where they did erythromycin, naproxen, and oseltamivir, showing better than 30 and 90-day mortality and length of hospital stay. So I think this is an interesting thing. A lot of our patients already get azithromycin with the oseltamivir because people are covering for community, but maybe it's worth putting naproxen as a cheap drug and it works seems to work. So I think this is something that we're probably going to go a little bit farther with, trying to get better with flu using NSAIDs to modulate the immune response. Rescue therapies. So we do talk about this big revolution in the treatment of ARDS, speaking with kind of from my critical care perspective, where we've gotten really good at lung protective ventilation, lower tidal volumes. Prone positioning has been shown to work in very severe hypoxia, as well as ECMO. I think ECMO is an important story to talk about because ECMO was something that really changed the way we dealt with acute respiratory illnesses. So ECMO was something that this is extracorporeal membrane oxygenation, for those who don't know, basically artificial lung machines. They fell out of favor in earlier trials, but newer experiences with better machines and better triaging of patients had a different kind of outcome. In 2009, H1N1, we had 2 national case series, 61 million cases of flu, 274,000 hospitalizations, 30% were admitted to the ICU, and eventually down there, 38% developed ARDS. And people, when they die from ARDS, are dying of refractory hypoxemia. So I think this also gives you an antiviral story, that patients who received antivirals less than 2 days, 20% less likely to develop ARDS and 22% less likely to die. But of those 24% with refractory hypoxemia, you could do something like ECMO. And for example, the Southern Hemisphere is much more liberal with the use of ECMO, and what they did is 1/3 of their mechanically ventilated patients received ECMO and had 21% mortality. And in the UK, there was a 55% decrease in mortality in those referred for ECMO. So that's an important caveat, because places that can do ECMO tend to be better at mechanical ventilation, tend to be better at ICU, so you do get a benefit just by being around 24/7 intensivists that are comfortable using very innovative ways of dealing with respiratory failure. In the U.S. ELSO registry, that's the Extracorporeal Lung Support Organization, 323 patients with 35% mortality. I think that mortality would probably be 100% were it not for ECMO. So I think this is something that was really important, and at the center where I work, we got very interested in this, and we came up with this idea. We wrote a paper in the Journal of Critical Care talking about improving care in pandemics, that coming up with the severe lung injury centers, because we do have centers for excellence for lots of things. That probably even for lung volume reduction surgery has a center of excellence, but we don't have one for acute respiratory failure or ARDS. And I think this is one way to do it, where you might think about how to regionalize care during a pandemic, so those patients don't languish at some community hospital for 7 days and then come to a hospital like this and there's nothing we can do because it's too late. So the last section of the talk, I'm going to talk about the vaccine. So our vaccine currently is 2 strains of A and 1 to 2 strains of B. Remember, we have there's sometimes different vaccines for southern and northern hemispheres some years. I wrote a paper kind of trying to make like a funny comment, because American Samoa is the U.S. territory, but it's in the southern hemisphere, so they don't get the southern hemisphere vaccine, which I wrote a paper trying to argue that they should be getting the southern hemisphere vaccine. But right now, there are different vaccines. The southern hemisphere vaccine isn't available in the United States. You have to go in the southern hemisphere to get it. Vaccination had this issue with egg allergies that you had to think about before. The question to ask a person when they say they're egg allergic is, can you eat scrambled eggs? If they can, you don't necessarily have to worry about it. We've got differences in efficacy between the inactivated vaccine, which is a standard vaccine, and the live vaccine, which was preferred for children. This is basically a menu now. You have trivalent vaccines, quadrivalent vaccines, high dose, normal dose, adjuvanted, non-adjuvanted, cell-based, recombinant, chicken egg, live, inactivated, intramuscular, intradermal. So it's very hard to figure out, and these are all available to anybody in the United States to pick from. So this is kind of my take through this. It may not be the same as yours I'm going to go through. So the one thing I wanted to bring out was the story of FluMist, because now FluMist is being returned into the U.S. market, and I think this is an important story to understand. In the past, FluMist was preferred. FluMist was the live attenuated nasal vaccine. It was needle-free, and it was mimicking natural infection by going into your nose. It was a live attenuated, cold-adapted strain. And it used to be preferred, then it became no preference, and then it became not recommended. And it was removed from the recommendations because of poor efficacy versus H1N1 strains, the pandemic strain. After the 2009 H1N1 pandemic, any year that was dominated by the H1N1 was really showing poor efficacy with the FluMist vaccine. Only in the US, not necessarily in Europe and Canada and other places. And that may be because our kids are so heavily vaccinated with the standard vaccine that it maybe was causing some interference. And basically what they've done is change the strain, and there's new data that was reviewed by the CDC just a couple weeks ago, and now it is back there with no preference, but it is available, so you will be able to spare some children the needle with FluMist. My favorite vaccine is the RIV, or the recombinant influenza vaccine. This is something that is made in insect cells. It is a recombinant vaccine that has really, really fancy technology made by a company called Protein Sciences, which just got bought by Sanofi. This is a cell-based form, and what you put in, it's a cloned recombinant hemagglutinin. It does not change. And when you look at the New England Journal paper that came out earlier this year, it was superior than the other vaccines, the standard vaccine, specifically against H3N2, which is a notorious egg-adapting virus that changes. So the last 2 seasons, I've gotten RIV myself. It's sometimes hard because everybody says it has to be for egg allergic, but you can ask for it by name, and they will give it to you. And that's what I've gotten. I think this is the wave of the future. This technology is really important, not just for seasonal flu, but for pandemic flu and for Zika. And I think it's important that this technology exists because it's really going to be a force with pandemic preparedness. For elderly patients, the high-dose flu vaccine really is showing a lot of benefit, that it does decrease influenza-like illness, decreases hospitalization. It is trivalent. It only has 1 strain of B. It is 4 times the antigen dose. So your arm is going to hurt, but hurt more. But I think it is the preferred vaccine for the elderly. Just a couple of things on avian influenza I want to talk about. This is something that's really been tracked for a long time. If you look on here, 1959 was the first time that we saw a true first avian virus jump into humans. But I just want to show you there's lots of ones. A couple to draw attention to. H5N1, most of you have heard of. That's been there for a while, since 1997. And then H7N9, which I think is the scariest of them all. But I just show you there's a theme of H7, so I do think that our pandemic virus, if I were to bet, is going to be an H7 because there's multiple incursions. The newest one was H7N4, just a couple of weeks ago was reported as well, H7N4. There are swine influenzas that happen as well. There are cases of H3. Anytime you see V, that means it's a swine variant. H3N2V, H1N1V, H1N2V. And usually they are tied to agricultural fairs. That's a picture of someone touching a pig. That's very common to happen at fairs. And that's where you're sort of driving these exposures. They haven't necessarily spread much more than that. But H7N9 is one of the scariest. It's about 1,500 cases, all in China, 40% mortality. Really dealing with poultry contact there. You can see what a live poultry market looks like and how easily these viruses can spread. And it's basically been going on since March of 2013. This is something that happened at the Butler Fair where I grew up. This is a sign from last year, I think, that they didn't have, or 2 years ago when they didn't have poultry exhibits because they were so nervous about avian flu. So this is something that you see even in poultry flocks in the United States. This is just a little bit of a summary on H7N9. So right now we're in the 5th wave. And what's scary about the 5th wave is there are more cases in this 5th wave than the other cases. And those changes I talked about with receptors and genes, it's starting to show more human tropism. We're seeing strains now that are antiviral resistant. We're seeing a change in the strain, so now the vaccine that was stockpiled by the U.S. government probably will not work against the strain that's actually circulating. And it's changing in chickens now as well. So there's lots of things going on with H7N9. And this is something that the CDC, on the very top right corner, it's called the IRAP. And that's the way the CDC evaluates novel flu strains. And A and B are both the highest ranked, and they're both H7N9s. So this is the highest threat level for any flu virus that we've seen from the avian species. So that's the one that everybody is watching. And remember, this is just to show you what that cycle is, that it's humans get infected either by swine as a mixing vessel or domestic birds like poultry, and it naturally is going through shorebirds and waterfowl. That's where this is a natural infection. A couple of other points to make about steps in pandemic emergence. What we have to show is that what has to happen is the avian strain must become widespread in wild and domestic birds. 1 or more humans must acquire, and the infection must replicate sufficiently to produce infectious virus, and then just get transmitted to additional humans, avoiding early termination. So with H7N9, I think we're around 3. So it's I think a very scary prospect. And that's just a little bit more talking about how they rank the IRAP tool. It's kind of interesting if you like flu. That's another picture from the Butler County Fair, the farm show. That's all I have in my formal presentation. So I'm happy to take questions on flu or any other infectious disease topic that you may have. Feel free to follow me on Twitter or read my blog where I talk a lot about infectious disease issues. And thanks again for your attention. I hope that was helpful and interesting.
The RIV vaccine, since you haven't decided February for next year's vaccine, as bad as everything else, is that able to Are we able to manufacture that in a much shorter time frame?
Yeah, that's an excellent question. So the question is about the recombinant vaccine. Does that shorten the lead time? The answer is yes, but the way that our flu vaccine strain selection is going on is that they're still making they make the same vaccine that everybody else does. But in the event of a pandemic, the RIV could be scaled immediately, and they could run batches much faster than in a situation.
Thanks so much for the talk. Any thoughts on prophylactic oseltamivir for folks who are at high risk for exposure, maybe hospitalized patients, people working in the hospital?
So prophylactic oseltamivir, so it does have an FDA indication for that. However, one of the dangers, so that the dose is half the dose. And what we saw during the pandemic was prophylactic cases becoming resistant, getting infected with resistant viruses. So you have to be very careful. I would do it only in select populations that are high risk, like a nursing home outbreak. And maybe I probably use the treatment dose. I probably wouldn't use the prophylactic dose because of the emergence of resistance with the single daily dose.
What is the cost of the rapid influenza screen?
The cost is probably, I don't know the cost off the top of my head. It's probably very cheap.
So it's much cheaper than the cost of therapy.
Right. No, not the cost of therapy, but the
cost of taking Tamiflu.
It is, but you have to remember that rapid test only helps you when it is positive. You need a molecular test to actually be able to effectively rule out influenza. So if it's positive, it helps you, but if it's negative, you cannot rely on a rapid influenza test. You need a molecular test. Yes.
Were the deaths in this country from this flu season due to the normal strains or more severe strains?
It's due to the normal strain, H3N2. All right, thank you again.
My understanding is it kept coming back.